Hey, thanks for tuning in, everybody. My name is Tino, and today I'm going to talk about the models for the coronavirus, the ones that we are using at the federal and state levels. I'm in California, Santa Clara County specifically, and the counties in the San Francisco Bay Area, and I believe there are six of them, they are coordinating a bit. They tend to mirror each other. Some break the mold a little bit more so than others, but I'm having serious questions about the data that the models are using and which ones we're leaning on more. And that's at the federal and the state level. It's a big basket of confusion, right? Now, I do take the virus very seriously. I know people who are vulnerable. I would never want to see them hurt, but I'm also concerned that the data is off and the solutions being proposed are severely destroying the lives of many people around the country and the world, short term and long term. So let's go ahead and get started. Now, the CDC lists 16 different individual forecasts, different types of models, and they talk about a national ensemble forecast, state level ensemble forecast, and so they are using a combination of models. Now, it's difficult to understand which ones they are leaning on more heavily, and so it's difficult to determine what is what at times. Now, there's so many different models and there's different ones with different focuses. I'm going to talk about three specifically in this episode. And I want you to keep in mind, I'm going to do an overview, right? I can drill down specifically into each and every one of these talking points, and I will do that. But for now, we need an overview. So, the Imperial College of London, they were initially leaned on very heavily, and there were a lot of interesting stories that came about with the Imperial College of London. First of all, one of the architects, Neil Ferguson of the Stay Home Order, he had to quit as a government advisor he had to quit as a government advisor on coronavirus because he violated his own recommendation. Why did he violate it? To see his lover, who happened to be married. Now, I'm not here to judge open relationships or whatever they had going on, but the facts are what they are and they need to be mentioned. His recommendations were a huge part of the shutdown in the UK and the United States, but he violated his own serious and concerning recommendation to stay home, to execute the stay home order, and that needs to be noted. Now, beyond that, there was an interesting article I came across, and it talked about Sweden's approach. And it's been a very hot debate. So I wanted to put some things into perspective about Sweden. So there was an article that was published on April 30th by the American Institute for Economic Research, and the Imperial College of London had only really released forecasts for the United Kingdom and the United States, but its model can theoretically be adaptable to any country by changing the inputs. And there was an organization right around the peak of the academic community's backlash against the Swedish government strategy. The group of researchers was called Uppsala University, and they attempted to do just that. They released a model for Sweden that applied the ICL, the Imperial College of London COVID-19 model, to project the effects of Sweden's response on both hospital capacity and total fatalities. Now, they presented a projection for an unmitigated response, aka a do nothing response. And it was suggested that Sweden would have to adopt a lockdown policy similar to the rest of Europe immediately to avoid catastrophe. Now, as the authors explained, under conservative estimates using their model, the current Swedish strategy would result in a medium mortality number of 96,000 deaths by the end of June. And that's a range of 52,000 to 183,000. Now, the proposed mitigation scenarios were predicted to reduce mortality by about threefold, while also avoiding a catastrophic failure of the Swedish healthcare system. Now, with even the most severe lockdown strategies they considered was supposed to cut that number to between 10,000 and 20,000 by May 1st, while preserving hospital capacity if they changed the policy by April 10th. So as of April 29th, Sweden's death toll from COVID-19 stood at 2,462, and its hospitals were nowhere near the projected collapse. Now, as of this video and this recording, the death toll on May 26 was at 4,029. The per capita number was a bit high, but the totals were nowhere near what was expected. Now, everybody who is producing stories about Sweden, they talk about per capita, per capita, per capita, but they won't talk about the numbers being significantly lower than any model projected. So we have to take that into consideration. Now, the ICL, the Imperial College of London, their team also delayed releasing the source code for their model for over a month. They finally released their code on April 27th through the popular website GitHub. However, they stated that the parameter files are provided as a sample only and do not necessarily reflect runs used in published papers. The code that they provided was only a sample. It wasn't even enough for a full peer review. So Imperial College of London, lots of issues there. They're still in the mix. I still see them on websites and in news stories. Neil Ferguson stepped down. Other colleagues and other professionals exist, but take that for what it's worth. Now, the IHME website, the Institute for Health and Metrics Evaluation, is the most widely referenced model right now. I'm not going to deep dive into this as much as I did with the Imperial College of London, but I went to their website and I wanted to see if the IHME model mentioned nursing homes or death certificates. Because, in my opinion, those two data points need to be confirmed in terms of, are they being applied in the models? And I'll get to the reasons why a little bit later. Now, nursing homes were mentioned once on their FAQ page, but it was hard to interpret and there wasn't much detail to it. Now, they have updated their model. This took place in the first week of May, but there have been serious questions throughout regarding their projections, both on the high and low side, as well as with some of their data points. I also don't know if they've been peer reviewed. I'm wondering if peer review is a universal problem or if that was an isolated incident to the Imperial College of London's model. Now, speaking of universal problems, potential, I have to look at the funding for these two institutions, excuse me. The Bill and Melinda Gates Foundation, the world's largest foundation, has dispersed over $6 billion in funding to 392 universities in 51 countries and higher education institutions over the past 5 years. And that's according to analysis produced by universityphilanthropy.com. Imperial College of London, heavily funded by the Gates Foundation. IHME is also heavily funded by Gates Foundation. Now, as an example, in 2017, the IHME received $279 million from the Gates Foundation. People have different opinions about Gates right now. I want to leave my own opinions out of this and simply point to the financial connections and the fact that vaccines are a big part of what his foundation does. Vaccines are not a guarantee. The effort to create one for coronaviruses in the past hasn't been successful, and there are concerns with the safety of the virus, even noted by Dr. Fauci. The potential for a conflict of interest does appear to exist in my eyes with the Gates Foundation and where they're funding and who's producing the models. Yet it's rarely spoken about by most journalists, and the ones who do aren't viewed favorably. Plus, there are multiple vaccine makers skipping animal trials right now, even with the dangers. And in one of the trials going on right now, there were some negative effects to some of the people who volunteered for the trial. Now, getting back to the models, there's been a bunch of different factors that do come into play here. Minnesota just recently changed its approach. They went to a model that was a little bit different, put in some different variables into it. There was a model that they were looking at in which Minnesota's stay-at-home order if it was extended until May 31st, it was almost as bad as the scenario where they opened up. There was about a 2.8% reduction in the overall predicted deaths over 12 months between the two scenarios. And 2.8% is 2.8%. Every life matters, and I understand that 100%. But there are variables and things that connect in terms of the economy, small businesses, depression, food shortages. There's so many factors into what the pandemic should overall entail. And a lot of those issues, they're spoken about in passing and in mention, but it's more of a quick story just to show that the information is being shared. But there's no real solution being put into place. Now, digging into California a little bit more. Now, I came across an article in the San Francisco Gate that mentioned some of the different models California is using and the disparities with the IHME model. For instance, the IHME model, one that takes into account a state's social distancing efforts, projects that California hospitals will hit peak resource use on April 13th. This is a little bit of an older article, keep that in mind. And the state's number of daily deaths will peak on that Wednesday. So it was roughly mid April when this was published. In addition, top-line figures for Kaiser Permanente's internal model, reviewed by San Francisco Gate, showed that the Managed Care Consortium expects peak resource use sometime in late April. The timeline is a week or two behind the IHME projections, but almost a full month ahead of the California internal projections. So why the discrepancy? SF Gate reached out to California's Office of Emergency Services for information on the science behind the state's internal model, but did not receive a response. Now, there's a doctor, George Rutherford, an epidemiologist at UCSF, and he's put a couple of different statements out there over time about this, but he said the state model uses two other models. One being the University of Pennsylvania CHIME model and Stanford University's model to make its own projections. While Rutherford is not entirely sure how the state weighs each model, he believes that the reliance on the CHIME model could lead to overstating the spread of the outbreak. The CHIME model is sensitive to case doubling over time, which is purely a function of testing. Rutherford put some numbers in with a case doubling of 3 days as opposed to 4 days. And full disclaimer, I'm not 100% sure exactly what that entails, but there was a huge difference. Doubling times are not what you want to hang your hat on since they're a function of testing, Rutherford said. Now, in another article in the Mercury News, there was a model that was referenced about AI. Now, I also noticed this on the CDC's website and also in a New York Times article where they were talking about the federal level and some of the different models being used there. And this is a model I haven't really heard about too much. Now, this was created by independent data scientist Yao Yang Gu. It uses artificial intelligence and an epidemiological methodology called SEIS. SEIS, susceptible, exposed, infectious, susceptible again, and they use this to make its own predictions. The model tracks the number of infections and deaths on a national and state-by-state basis. The model, the website, I think what they're calling it is C19 Pro, and that site, they have actually had some pretty stern critiques about the IHME, the Institute for Health and Metrics and Evaluation, and talked about their numbers being more accurate than the IHME's. Now, I do have questions about the AI technology because they're talking about using factors such as mobility of the population and epidemiology, and it's a combination. So is the tracking that they are using, is it legal or illegal under the umbrella of a pandemic? Laws have changed, and we need to understand that. And so I'm not sure what kind of permission or what kind of leeway they were given in order to use that type of effort, but that's something that needs to be questioned. Now, another thing that I had a question about was whether or not they were accounting for nursing homes and death certificate classifications as well. Those two metrics, I still believe, need to be absolutely 100% implemented into any model. Now, there's been horrible nursing home mismanagement, elderly care facilities, and the death certificates I'll get to in just a moment as well. So when I went to the C19 Pro website, they have a bunch of different updates. They talk about updating their projections after an analysis of recent studies showing promising treatment results, possible seasonality effects, high mask wearing compliance, slow reopenings, widespread reopenings, and more. Now, one thing that I did notice is even when I went to their model details page and on their updates section, nursing homes and death classifications aren't mentioned there either. And if they are, it's not about using them and implementing them into the models. But as far as I could tell, they weren't there. Those two titles. Now, let's get to death certificates. Dr. Scott Jensen, who is also a Minnesota state senator, said he received a 7-page document coaching him to fill out death certificates with a COVID-19 diagnosis without a lab test to confirm the patient actually had the virus. Now, this claim and the uncertainty of the classifications is a real issue. Here you have a state senator talking about it. And when you look at the possibility for uncertainty here, one of the things, the National Vital Statistics System, which is part of the Centers for Disease Control and Prevention, CDC, provided new guidelines for those who submit death certificates. It said they should list coronavirus if it was assumed to cause or contribute to a death. Now, the word assumed is a very powerful word. Personally, I would think that in the middle of a pandemic, assumptions need proper classifications and should come with very detailed explanations. Meanwhile, there are questions about yearly average stats with multiple types of deaths ranging from pneumonia to heart attacks. In Colorado, there was a story that came out, and nearly 300 fewer people have died from COVID-19 than were originally reported after the Colorado Department of Health and Environment changed the death statistics. Colorado had been reporting at the state deaths among people who had COVID-19 at the time of death, and the cause of that death may or may not have been COVID-19, Dr. Eric France, CDPHE's chief medical officer, said. Now, this came out in mid-May, May 15th, if I'm not mistaken. And what he also said was, we started to hear stories about, are these correct or are these incorrect? France said. One of the stories came from Montezuma County, and this is just one story. And I'm not saying that all of the stories are as wild as this one, but the county coroner said that the man who had COVID-19 died from ethanol toxicity, basically alcohol poisoning. The coroner said the state, however, classified the death as coronavirus related. The change in numbers at the time lowered the death total about 23% as far as I can tell. Now, that's something that you can look up. The story is out there. There's multiple stories coming and surfacing about that. And the uncertainty is something that needs to be addressed. Now, there have been issues with the CDC and Dr. Birx, and there was a story on Fox News 6 Now, and I'm pulling stories from New York Times, Mercury News, local, nationwide, alternative media sources, Fox News. It doesn't matter. I'm trying to get as much information as I can. So the article states that 3 administration officials said Dr. Birx, the task force response coordinator, has urged the CDC to exclude from the death count some who were presumed infected but did not have a confirmed lab result, and those who had the virus but might not have died as a direct result of it, according to the news outlet. Now, the Washington Post has reported that a recent discussion on COVID-19 data, Birx told CDC Director Robert Redfield that there is nothing from the CDC that she can trust. Now, it's important to note that some experts like Dr. Fauci think that there is an opposite effect, but the confusion and uncertainty is even more reason to sort through the mess for a better and more accurate understanding. Now, let's go ahead and dive into the CDC, right? So, look, I could go into this really significantly. I'm going to be a little bit broad. The CDC, early on, they sent out tainted coronavirus kits with the actual virus. Now, this went out to roughly almost all of the 100 state and local public health labs. Okay, that's according to the Food and Drug Administration. This setback, there was problems ranging from researchers entering and exiting the coronavirus laboratories without changing their coats, to test ingredients being assembled in the same room where researchers were working on positive corona samples. It was just a mess, and it set us back at least a month in terms of testing. Now, I have my own issues with testing accuracy, whether it's PCR or antibody tests. I have my own issues there, and we're not going to dive into that right now. But that was a huge setback early on, and they weren't really held accountable. They did lose credibility as the nation's leading public health agency in many people's eyes, but that was something that was a huge setback. Now, I came across another situation that just happened about a week ago. Now, this is from The Atlantic, but multiple sources are reporting this. And The Atlantic reports in their article, the CDC is conflating the results of two different types of coronavirus tests, distorting several important metrics and providing the country with an inaccurate picture of the state of the pandemic. We've learned that the CDC is making, at best, a debilitating mistake, combining test results that diagnose current coronavirus infections with test results that measure whether someone has ever had the virus. They're mixing up the different results, the different tests. So as we look at the CDC and we look at some of their major mistakes, this is a huge mistake, right? The government's disease fighting agency is overstating the country's ability to test people who are sick with COVID-19. The agency even confirmed this with The Atlantic, that it's mixing the results of the viral and antiviral antibody tests. Okay, let's go on from there. So you can see with the death certificates, and you can see with the CDC and some of the things that we're leaning on with them, and there are so many questions in play in terms of our strategy right now, and I'm concerned that our strategy is being executed based on early models and what their projections entailed, and that we haven't really pivoted. So, nursing homes. The AP News reported that more than 4,500 recovering coronavirus patients were sent to New York's already vulnerable nursing homes under a controversial state directive that was ultimately scrapped amid criticisms it was accelerating the nation's deadliest outbreaks. Now, the AP compiled its own tally, and there are other sources that are compiling their own tallies as well. And this was the directive was issued on March 25th, and it wasn't reversed until May 10th, even though there were multiple complaints coming forward about what was going on. Now, there has been Cuomo has spoken on this. There's a lot of politics being played. I'm not going to dive into that right now at this moment, but there was some seriously mismanagement going on, not only in New York. This is nationwide, right? So, the New York Times, they've reported that 1/3 of all deaths have come from nursing homes. There are other sources and reports that actually say it's higher. But in California, according to the LA Times, nearly half of all deaths related to COVID-19 are linked to elder care facilities. That is based on a data analysis that the Los Angeles Times had found, with the state releasing new data suggesting that there have been many more outbreaks than previously disclosed. Right? You're talking about half of the deaths in California related to elder care facilities, nursing homes, and others. Now, knowing all this, I haven't seen a clear-cut strategy to address this, and I haven't seen any of this mentioned in the models. Now, there's another source that I'm going to point to, and this is freeop.org. And this is an article that was updated on May 22nd to reflect the most recent statistics. But based on a new analysis of state-by-state COVID-19 fatality reports, it's clear that the most underappreciated aspect of the novel coronavirus pandemic is its effect on a specific population of Americans, those living in nursing homes and assisted living facilities. So, according to the Centers for Disease Control and Prevention, CDC, 5.1 million people live in nursing homes or residential care facilities, representing 1.6% of the U.S. population. And yet, residents in such facilities account for 42% of all deaths from COVID-19 for states that report such statistics. There are 11 states that don't even report these types of statistics. Now, one thing that they also mentioned is that they also estimate that nationally, the share of fatalities from nursing homes and residential care facilities is 43%, and that it's 53% outside of New York State. Now, New York State ballooned, right? There's all kinds of, the volume there is way higher, and there's a different demographics that are being affected, and their numbers look a little bit different than most around the country. Now, this report, they have their calculations available in an online spreadsheet for public review. And I'm going to list all of these different sources in the description of this video. Now, when it comes to the different variables, I mean, we are over 36 million people that have filed for unemployment at a time when people would depend on work to provide healthcare benefits. And a lot of those jobs are not going to come back. Now, there are hundreds of thousands of small businesses that have shut their door permanently, and millions more are in danger of doing the same with a continued or new shutdown that they're already prepping us for down the road. Meanwhile, there's a billionaire class that have seen their fortunes soar by billions during the 2 months of the lockdown. So we look at the cause and effect, right? There are food banks that have been completely overwhelmed by demand in cities like Pittsburgh, San Antonio, Phoenix, and residents have been lining up for hours at these food banks to address the food banks in their attempt to address a massive influx of need. Some of the organizations have been forced to turn people away, while others are struggling to maintain the supplies necessary to keep up. So, one other thing that I want to talk about, there's talks about international flights coming from China, coming from Europe, coming from Italy, and there's almost like this weird connection of dots where the people act as if the virus went from China and then directly to Italy and then from Italy to New York, and that's not the way it works. International flights were going all over the place, right? Into Washington D.C., into the San Francisco Bay Area, into all of the major cities. Now, obviously there's a higher volume in certain areas than others, and then you have to look at the density of the population, right? But I look at what's going on in California, and there are in the Santa Clara County, a lot of the different types, the volume of people who've gotten the infection. There was a story about a heavy presence in 5 different zip codes in East San Jose, which is heavy in Latinos. But I'm thinking about these international flights, and I'm thinking about who is going on these international flights, and when they come home, and when they go to these tech conferences and these different types of conferences, and even though East San Jose is a dense population, San Francisco isn't more spread out, so to say. I mean, the idea that it's specific to these pockets of population where a lot of the folks that are in these areas aren't traveling internationally, there's something that doesn't add up, and I can't put my finger on it, and I'm not going to make any accusations, but there's some math there that doesn't add up. Speaking of math that doesn't add up, people have been saying this virus has been around since November. Okay, you're talking about reports initially out of China in December. You're also talking about holiday travel around Christmas, around New Year's, right? And from Italy to Spain to the United States, there are people in the United States that say that they think that they had this as far back as December or January. And so, in my eyes, when I look at the statistics and the way that they start in the middle of March, there's an entire month of February that is absolutely missing from the conversation. Okay, that there are no statistics in February. And even if the testing was absent, there were no oddities being reported by hospitals that I'm aware of. Dr. Fauci was still minimizing the effects of the virus in late February, weeks after multiple countries reported cases and after the WHO, which has had its own issues, declared a global health emergency on January 31st. He was still minimizing it in the States, in the United States, a month after the first U.S. case was reported back in January in Washington. So this brings me to the Santa Clara County. Now, Dr. Sarah Cody, who is the health officer and public health director of Santa Clara County, California, she's highly qualified. And her initial reactions are something that I've actually applauded to a certain degree. There were a lot of unknowns. She was one of the first to act in a time of uncertainty, in a time where there was contradictions everywhere at the highest levels. She acted appropriately, and there are many people that credit her with limiting the spread of the virus here in the Santa Clara County. However, even with her tons of experience with investigations and diseases, and she even had a 2-year fellowship at the CDC, I'd be very curious to see and hear her opinions on some of the actions from the CDC and some of the mistakes that they've had that have seriously cost us in terms of time. Now, on January 23rd, 2020, 3 days after the first confirmed case in the U.S., she led efforts to establish an incident command center, according to her Wikipedia page. Now, I don't put all of my stock into Wikipedia, but this is from her page. Now, in the early days of the outbreak, Cody and her team were responsible for contact tracing. On March 3rd, after the rate of transmission had become nearly impossible to contact trace, she began to issue guidelines recommending the closure and cancellation of public gatherings. So on March 3rd, it was determined that the rate of transmission had become nearly impossible to contact trace. But here we are, more than 2 months later, and countless additional cases, and we just put $100 billion into this. There are many experts that say that it's too late for this. This should have taken place back in mid-January. But then you have the top dog in infectious disease minimizing it well into the third week of February. And then here we are on March 3rd, where we stop the manual contact tracing for some reason when we go ahead and implement the stay-home orders. If anything, it should have been put into more effect once we had controlled the situation a little bit more and had people in isolation, so to speak. It would have been much more effective at that moment. Why shut it down then? Now, right now, Dr. Sarah Cody has more power than my city council. This is true elsewhere during the pandemic. Laws have changed. We need to understand that. Now, I am concerned about the manual tracing. I am concerned about the digital tracing that Google and Apple have just finished their software for in order to implement a mobile app strategy, which would require the uploading of data and DNA on some database. We don't have real privacy legislation in there to protect our data, and that's been a huge concern. Now, databases can be hacked. That it's as simple as that. Now, there is so much concern that on April 30th, U.S. Senator Roger Wicker, chairman of the Senate Committee on Commerce, Science, and Transportation, announced plans to introduce jointly with several co-sponsors the COVID-19 Consumer Data Protection Act, according to the National Law Review. Now, there was a Q&A that the Mercury newspaper did with Dr. Sarah Cody on May 4th. And one of the things that they've talked about, I'll go through a couple of the questions and answers. One of the questions was, the shelter in place order has been in place 6 weeks now. Has that changed how and where people are getting sick now? She says in an answer, we do not have the data. Since case counts started to accelerate in March, we have not been doing those same case investigations of how you might have gotten this infection, which was the whole reason we put shelter in place into effect. That's the model we need to get back to. Well, if we need to get back to it, why did we ever go away from it? Another question, how do you know when we've had enough testing to ease restrictions? Health officers across the Bay Area, we made an attempt to name a number, an indicator we'd all follow. That was 2 tests per 1,000 residents a day. Now, long story short, that translates to about 4,000 a day. Now, she says you can see it's picked up a little bit, 800 to 1,000 per day. And this is beginning of May, so this might have changed by now. Maybe we're at 20 to 25% of the way toward our goal. The more we test, the more cases we'll find. She even says it right there, and I'll get to that in just a moment. The more we test, the more cases we will find, and the more testing we will need to do with their contacts. Maybe we didn't set our goal high enough and have to increase it. 4,000 tests per day is nothing. When I do the math in my head, and keep in mind, I'm not a professional. I'm a citizen who is doing some of my own research to piece together some of these bits of information, because information has been everywhere. But 4,000 a day in the Santa Clara County, when you look at the total population, and then the fact that people are going to have to retest, because if they go out to work or if they go to the store, then that changes the possibility of them being negative or positive, or negative, excuse me. And so the numbers don't add up. When I look at these numbers and I hear these numbers, we are never going to be able to get to enough tests. And then another thing was the flattening of the curve with the cases and things of that nature. Well, as testing goes up, so will the cases. But nobody talks. A lot of these news outlets will not report it that way. All they say is cases going up, cases going up, cases going up, but they don't talk about the fact that testing has increased as well. So, there's a lot of things to be concerned with. Now, I'm curious, where are the regular nationwide and local roundtable discussions on TV with different perspectives? Right? There are no perfect models. There are uncertainties. If anybody is saying that the science is settled, then they're not paying attention. Now, there are different organizations that should be leaned on a little bit more heavily, but as we continue to go on and they continue to show their capabilities or lack thereof, then we need to be able to pivot. And as of right now, I mean, government officials and health officers are calling this a pandemic, and they say they want to provide real transparency, but that doesn't feel sincere anymore. Are the models competing with each other, or are they truly collaborating? People and experts everywhere say a second wave is coming. Flattening the curve always meant extending the curve. The public has been hearing about another shutdown for a long time, and now we're getting into the month of June. And I've seen reports of people talking about this is going to coincide with the flu season. If we're having questions about the death certificates and the classifications now, can you imagine the chaos that we're going to have if this coincides with the flu? We need to address this now. Media and experts talk about cases going up. And again, the cases are going to go up as testing goes up. Most news sources just won't report it that way. They also never mention the ratio of new cases, whether people are asymptomatic, had minor or severe symptoms. It's still unknown how long someone can transmit the virus. Is it a few days? Is it several weeks? How long can someone test positive? And again, the tests, PCR, antibody, they're highly volatile. All of them. Now, I'm going to reiterate. Laws have changed under the pandemic, and I'm just not sure the virus, as is with the data we have, actually qualifies for the strategy being taken. I take the severity of the virus for what it is, for sure. Frontline workers are obviously encountering something real. I've heard multiple doctors speak about the ventilators and the high mortality rate there. That's another important topic to discuss at another time. Now, I don't want people, I don't want to send people to their deaths. I don't. But the laws and the changes in laws allow for severe actions to be made by elected and unelected officials under the umbrella of a pandemic. And these health officers, these health directors, they are unelected representatives of unelected officers, excuse me. And that is a topic that needs to be discussed much more thoroughly. Now, the models and metrics we use to determine our responses are more important than ever. Data is king, and I'm concerned the data that we're using to shape our decisions is incomplete. I'm concerned that the opening up measures that just took place will override the other data points and will be used as a sole reason for an uptick in cases, even though testing continues to increase. Now, if we add in the nursing home numbers and look at the numbers in Colorado, assuming the corrections made in Colorado represent a nationwide trend, which is a big assumption, I admit that, those deaths account for roughly 50 to 65% of the deaths. Regardless, the nursing home situation totals are a huge percentage of the deaths, ranging from 33 to 42% based on sources used in this video. And it's even higher, the percentages are even higher in California. People have to start looking to our local elected reps and to the county health officers for more transparency and more details on the models used. And if you're not in the Santa Clara County, this can still apply to you and to your health directors and to your local elected reps, right? Are they knocking on the governor's door? Are they pushing Congress to pass legislation without the political gain? Local elected reps may not have much power right now, but this is also why they were elected. Awaiting orders without asking consistent questions after so many contradictions and so many errors have taken place simply can't continue. That's why I'm encouraging people to reach out to local elected reps and county health officials in a productive way and ask, what are you doing to provide people in your cities and counties reassurances that you're doing everything in your power to get to the bottom of some of these glaring questions and problems with the process? Do you know which models are being used? Do you understand which metrics are being used? I asked one of my local city council members if they are questioning the narrative at all. The short answer was no. That was understandable at the time, considering the dynamics and technical aspects, which are admittedly above my pay grade. But I'm at the point now where that's no longer something I can fully accept. There are multiple reasons people are questioning the information coming out, and it's not always the reasons you see on TV. Hopefully, people will understand why I'm concerned about the questions surrounding nursing homes and death certificates, among other issues. Tough questions need to be asked and answered. Are we really taking the most responsible route right now? Are we going to learn from the mistakes we previously made moving forward, or simply default to the same actions without any questions? There are too many variables to just default. As complicated as the models can be, we have to ask, are the experts leaving out some of the most important data points? That's all I got for today. Much love.